So during our panel discussion, I have received Professor Hu. He want to ask 2 questions. So the session we will just the host of the conference will just deliver to the Professor Hu. You can ask whatever you want to ask. Thank you.
Professor Gualiano, and I have 3 short questions. The first one is about, we are comfortable to use 6 to 9 cycles of TCHP followed by DB05 approach.
You mean to reduce the number of T-DXd rather than 14 in case of residual disease? This is an interesting question, I believe, because if you have a minimal residual cancer burden, yes, why not? But we need to have at least a real-world study on this. So my proposal to you, since in China you can complete a trial in less than 1 year, you do a large prospective study supported by Daiichi and AstraZeneca, in which you stratify according to residual cancer burden, and you do a de-escalation in patients with minimal residual cancer burden. So I believe for some patients, you are right, we don't need the 14 administration. Absolutely.
Yeah, why I ask question, because the TCHP regimen is mostly common used neoadjuvant regimen. And the second question is in your presentation in the DB05 trial, and only 70% finished 14 cycles of the T-DXd treatment. So how to manage the patients in the other 30% of patients, how to finish the 1 year of the anti-HER2 treatment? Do you have any suggestion?
So personally, I believe, of course, that compliance to adjuvant treatment is an issue, but I also experienced this with T-DM1. I believe 14 administration of T-DXd in the adjuvant after neoadjuvant treatment is a huge effort for a patient. We need maybe to reduce the dose, and eventually, if you cannot afford for hematological toxicity or any other type of toxicity treatment, you should stop. In that, for 28%, we have almost 15% with ILD. If you remember, in San Antonio, the data of concurrent T-DXd adjuvant radiotherapy have been presented, and around 16% developed a grade 2 ILD. And for the other ones, those reduction can be really the option. But you raised an excellent point. Yes.
And the third, also on third question is about on the giredestrant, how to combine the giredestrant in the adjuvant setting.
This is an excellent question. So personally, I believe giredestrant is potentially practice changing. Maybe some patients can receive giredestrant rather than AI plus ribociclib, because also in the intermediate risk, giredestrant was better. So should be integrated in all patients frontline. So if you have a patient not candidate to a CDK4/6 inhibitor, personally, you should, when available, with reasonable cost, you should propose a giredestrant. In my opinion, I also would switch to giredestrant after 2 years of AI CDK4/6 inhibitor. Ideally, I would combine giredestrant with CDK4/6 inhibitors.
Oh, thank you.
Yeah, thank you very much, Dr. Hu and Dr. Curigliano, for your sharing about the question.